and light colored alternating rings, as you can see in the image. A light is thrown on this placido disc. This light reflects these rings onto the patient's cornea, and we are able to visualize these rings. Let's see how, everybody. So this is how a placido discs work. This is a viewing aperture in the center with a lens. This is the handle which we are holding. Reflection. When we throw light on these rings are reflecting their image onto the patient's cornea, as you will be able to see in the image on the right side. Based on the shape, the size, the undulation seen in any of these rings, we are able to determine whether the cornea is absolutely smooth in surface or there are some problems. As you will be able to see, all these rings seem equidistant and there does not seem to be any undulation. For example, if there is an undulation in this ring, that this ring goes like this, then we would have known that there is an undulation in this part of the cornea, that there is an ulcer, there is some pathology in this part of the cornea. That is how simple placido disc to affect it. That is why it is mandatory again to measure the corneal thickness whenever you are in doubt about the intraocular pressure values. Done, everybody? So that's all about our second investigation, that is pachymetry. Moving on to the third investigation, that is topography. Topography, guys. Topo means the surface. Topo, yes. Thickness. The thickness of the cornea. So when we are measuring the thickness of the cornea, what we should know is what is the normal corneal thickness. The normal corneal thickness is 0.54 mm. Okay. For a range, we say 0.5 to 0.6 mm. Or if we say it in another mathematical term, it becomes 540 microns. That is the normal corneal thickness of the cornea. Remember, when we're talking about these figures, this is the central corneal thickness. See, we are majorly concerned with the central corneal thickness. Apart from that, corneal thickness will increase. Central to peripheral, the corneal thickness will increase. Am I clear? So all these figures pertain to the important central corneal thickness. Now, how do we measure the corneal thickness? We measure the corneal thickness by a lot of instruments which are just called pachymeters. They can be handheld instruments, they can be cumbersome machines, not going into all that. The end result that we are able to see in almost all the techniques that we use or all the instruments is an image like this. If you see carefully, this is my cornea, everybody here. This is my cornea, like this. Now, this is what we are measuring, the thickness from the epithelium to the endothelium. We get a map here. You will be able to see in the center it is 666. As we go to the periphery, in this case, it is increasing to 673 here, 638 here, and various others. Okay, so we get a lot of data based on the various values. When do we do pachymetry? Why are we doing pachymetry? That is the question. So, uses, I can say. Why are we measuring the corneal thickness? Number one, in cases of LASIK. When we need to do LASIK, we need to ablate the cornea. Ablate means we are burning the cornea, so we are making the cornea thinner. So when we know that during a surgery we will make the cornea thinner, we need to be aware of the pre-existing corneal thickness. What if the cornea is already thin? Then we won't be able to proceed with LASIK. So LASIK is contraindicated if corneal thickness is less than 450 microns. So that is why before LASIK it is mandatory to do corneal pachymetry. Secondly, in cases of IOP measurement, when you are getting a borderline IOP, high or low, everybody, yes, then you need to think about the corneal thickness. Why, everybody? Because as we should know that 1 mm Hg IOP is directly proportional to 10 micron corneal thickness. That means IOP falls high, G, IOP is directly proportional to 10 micron corneal thickness. That means IOP falls high if corneal thickness is more, IOP falls low if corneal thickness is decreased. Okay, so based on the corneal thickness measurements, our IOP measurement gets affected. That is why it is mandatory again to measure the corneal thickness whenever you are in doubt about the intraocular pressure values. Done, everybody? So that's all about our second investigation, that is pachymetry. Moving on to the third investigation, that is topography. Topography, guys. Topo means the surface. Topo, yes. So if you have ever seen a Discovery Channel or National Geography Channel, everybody, so there they have topographic cameras to map out entire large areas, everybody, where there is a hill or there is a river or there is a flat area, yes. So we are seeing the surface. So topography is done to examine the corneal surface, whether the cornea is smooth or there are some undulations in the cornea. Yes, as simple as that. Now, what are the instruments we use? First instrument, you will be able to see the image on the right side of your screen. This is called as a placido disc. This is the most basic instrument, consisting of dark and light colored alternating rings, as you can see in the image. A light is thrown on this placido disc. This light reflects these rings onto the patient's cornea, and we are able to visualize these rings. Let's see how, everybody. So this is how a placido discs work. This is a viewing aperture in the center with a lens. This is the handle which we are holding, and these are the rings of reflection. When we throw light on these rings are reflecting their image onto the patient's cornea, as you will be able to see in the image on the right side. Based on the shape, the size, the undulation seen in any of these rings, we are able to determine whether the cornea is absolutely smooth in surface or there are some problems. As you will be able to see, all these rings seem equidistant and there does not seem to be any undulation. For example, if there was such an undulation in this ring, that this ring was like this, then we would have known that there is an undulation in this part of the cornea, that there is an ulcer, there is some pathology in this part of the cornea. That is how simple placido disc topography is. But apart from placido disc topography, can we use other instruments? The answer is yes. So the second instrument that we use is known as orb scan. This is a machine based on a principle of slit scan imaging. Okay, so this works just like a slit lamp. It throws an oblique light and we are able to see each part of the cornea in scans. Not going into the detail, not important. Then the last instrument which we use commonly, guys, you will see this name being commonly used in the ophthalmology department if you are posted or if you have ever been into a cornea clinic, is Pentacam. This is a camera which gives us 5 measurements. That is the basic name, Pentacam, camera giving us 5 measurements. So this is more than a useful instrument. What else does it give us apart from topography? Let's see. So the first thing it measures is corneal thickness. The second thing it measures is corneal curvature. The third thing it gives us is the topographic elevation map of anterior surface of cornea. Then it gives us the same topographic elevation map of posterior corneal surface. So through the use of Pentacam, you will basically be able to see whether there is a problem in the anterior or the posterior surface. Any epithelial or endothelial problem, both you are able to know through the use of Pentacam. And lastly, it gives us anterior segment imaging also. Okay, you're able to see up to the iris if there is any problem from the cornea up to the iris also. Pentacam, 5 uses. Am I clear? But the main use is obviously the topography part. All the others are accessory uses of a Pentacam. Pentacam is again usually done before a case of LASIK is done or a LASIK surgery is done. If we have a keratoconus, we want to see the progression. Keratoconus is cone-shaped cornea. So whether the cone is progressing or not, if the cone is progressing, the topography will change. So in a lot of conditions like this where we have any shape or surface abnormality of the cornea or we are about to do a corneal surgery, we always tend to do Pentacam before those things. Am I clear to everybody? Done? So that's all about our third investigation, that is topography. Moving on to the fourth special investigation, the use of vital stains in the cornea. Now, why are we staining the cornea? That should be the question that you should be asking yourself. So there is a disease called corneal ulcer. Have you heard of this, everybody? Yes or no? Yes. So if there is a corneal ulcer, let's see everybody, let me try to explain it to you. Let's say this is my cornea. Okay. Now, ulcer basically means a wound. So let's say a wound has been created into the cornea, damaging its epithelium, a little bit of stroma and everything. Now, what you want to do? You want to be able to ascertain the size of this wound or ulcer. You want to be able to ascertain the shape of this ulcer. Cornea is transparent. So to be able to discern something transparent from transparent, you need to have some color or dye which will stain the part. Yes. So we can use a couple of stains. The first stain that we will use, you will see, will stain this. What are we saying? The base of the ulcer. Another stain can be used to stain the margins of the ulcer. So we have a couple of vital stains and some more also, which we can use in the diagnosis of corneal ulcer primarily. Am I absolutely clear about this, everybody? So let's start with this. The first stain, fluorescein dye. Fluorescein dye stains areas of denuded epithelium. Denuded epithelium, or I can say in simple English, areas where epithelium is aberrated or lost. Okay, so that means what is it staining, everybody? It is in effect staining the base of ulcer. Am I clear to everybody? By staining the areas wherever the epithelium is broken, it is staining the base of the ulcer. Now, this is a strip of fluorescein. So let's say this is a complete white strip of fluorescein with an orange tip. So it is an orange colored dye. Okay, we take a strip, we put it into the lower fornix, we stain the whole cornea or the surface of the eye. Then, if you see, we use cobalt blue light to illuminate. Okay, after we have illuminated this by cobalt blue light, everybody, wherever fluorescein dye is able to stain, those areas are visible as green color. So visible as green fluorescence. Am I clear to everybody? Orange color dye, blue light, fluorescing as green color. So if this is the part that the cornea is getting stained off, we know that this must be a case of corneal ulcer. Am I clear to everybody? No confusion about this? What are the uses of fluorescein dye? So number one, obviously, as we've just discussed, it can be used to diagnose corneal ulcer. Secondly, everybody, if you have seen the lecture on glaucoma, we know that this is used in cases of applanation tonometry. Specifically, if you remember guys, Goldman's. When we do Goldman's applanation tonometry, then also we have to use fluorescein strips to stain the cornea, then only we are able to do this. Thirdly, everybody, Jones dye disappearance test. Again, this has been discussed in detail on the lecture on lacrimal apparatus, guys. So this is one test which helps us diagnose the cause of watering or epiphora or hyperlacrimation. And lastly, Siddle's test. Siddle's test is a test which is done in cases of penetrating trauma. Discussed in detail again in the lecture on ocular trauma. Am I clear, everybody? No confusion about this, I hope everybody. Yes. So these are the 4 uses. Every chapter they have been discussed for you here to answer as an MCQ. Now, the second vital stain or the second dye that we can use is rose Bengal dye. Okay. Now, as you will be able to see the image here, everybody, this is the image which shows us rose Bengal dye staining. As soon as I use the name rose, we know we are talking about which color, red color, or we are talking about pink color. So we are able to see a stained area in red or pink color. Okay, that is telling us that we have used a rose Bengal dye. Now, what is rose Bengal dye staining? So rose Bengal dye stains devitalized, or I can say necrotic tissue. Okay, now if you know the healing of a wound, how does the wound heal? From the base or from the margins? Obviously from the base. That is why our body has inherent mechanism to keep on clearing the base, everybody, such that all the necrotic tissue gets deposited in the periphery. That means at the margins. So by staining this devitalized or necrotic tissue, we are basically able to stain the margins of ulcer. Okay, everybody, that is what I had drawn if we see carefully in the image at the top. The base was stained by green color fluorescent dye, the margins were stained by red color, that is rose Bengal dye. So if we remember this image, we are basically able to remember the use of both these stains, that is fluorescent stain as well as rose Bengal dye stain. Done, everybody? Now, there is another dye which is used very commonly these days. I'm writing the name, you may have heard of it, you may have seen it. Lissamine green dye or stain. Okay? In terms of the ability to work, this is almost same as rose Bengal dye. Why? Because this also stains our devitalized and damaged tissue. But it has the advantage, it is not toxic to healthy ocular tissue, as it does not stain them. Rose Bengal dye will be staining our lesion, but it also stains lightly all the normal ocular tissue, whichever is not damaged. So it can lead to toxicity. But Lissamine green dye is absolutely free from this healthy ocular surface damage. Yes, that is why these days we see it getting preferred over rose Bengal dye. But the main use of Lissamine green dye is to diagnose dry eye by conjunctival staining. I'm discussing corneal vital stains, I know, but I'm saying its main use is by conjunctival staining. It does not mean that it cannot stain the cornea. It can stain the cornea also, but the main use is in conjunctival staining. As you will see in the image here, everybody, in this area, everybody, the temporal part and the nasal part of the eye, you will see a faint green stain on the conjunctiva. This occurs in dry eye affecting the conjunctiva, leading to stippled appearance, everybody. Yes, after the conjunctiva is affected, then in the later stages of dry eye, you will see the cornea getting affected. And if we use Lissamine green dye in those stages, you will see stippled appearance of Lissamine green dye even on the cornea. But as a question, as an understanding, this is a very important tool to diagnose dry eye, Lissamine green dye. Done. Now, the last stain which we can use, everybody, is called as Alcian blue dye. You must have heard about this, you must know this name, everybody. Alcian blue dye is used to stain 2 things. Number 1, any mucin deposits. So if there is a pathology in cornea on the ocular surface with mucinous deposits, then you have to resort to Alcian blue dye. Or in case there is some filamentous pathology, then you need to use Alcian blue dye. Am I absolutely clear about this? Yes. So the 2 important dyes that we have, which we use commonly, which we study commonly in our 3rd years and in our MBBS days, is number 1, fluorescein dye, number 2, rose Bengal. The same job that rose Bengal does is better done by Lissamine green dye, and it is one of the important dyes to diagnose dry eye, and Alcian blue dye with some accessory uses. Okay, everybody, done. Very important topic, corneal vital dyes or corneal vital stains, everybody. Moving on, everybody. A very simple investigation, confocal microscopy. You will not see this commonly being done. This is more of an experimental investigation, everybody. Very rarely done. It is used to visualize on everybody. Bengal does is better done by Lissamine green dye, and it is one of the important dyes to diagnose dry eye, and Alcian blue dye with some accessory uses. Okay, everybody, done. Important topic, corneal vital dyes or corneal vital stains, everybody. Moving on, everybody. A very simple investigation, confocal microscopy. You will not see this commonly being done. This is more of an experimental investigation, everybody, very rarely done. It is used to visualize all the layers of cornea in vivo. Okay, so in vivo, if you need to visualize them, usually done for some kind of study purposes and all, then we use this investigation called as confocal microscopy. Period. Nothing else about it. The last investigation, everybody, which you have heard of, I hope, is called as corneal esthesiometer. Esthesiometer, as soon as I say, you know, I'm talking about what, everybody? Corneal sensations. So it is used to examine corneal sensations. As we know, corneal sensations can also be examined by, everybody, cotton, yes or no? Cotton wisp. Again, this cotton wisp and the whole corneal sensation fundamental has been explained in the basic anatomy. I hope you have seen it. Here, I'm just talking about the investigation that is corneal esthesiometer. Yes? So this instrument, everybody, this image that you see, image A here, this is a pen-like instrument with a thin filament which comes out from this. Yes? The maximum length of this thin filament is 6 centimeters. The filament will touch the cornea of the patient. We open it completely first to 6 centimeters. We touch the cornea. We see whether the patient is able to feel the sensations or not. If you're not able to feel the sensations, we retract. I hope you are able to see this scale here, everybody. Yes? So we are able to retract this filament, everybody. We retract it by 0.5 centimeter, from 6 to 5.5, 4.44. At whichever point the patient is able to feel the sensations, we record that. The smaller the length, that means more is the anesthesia. So I will write it for you. Smaller the length of filament which elicits the corneal sensations, it means lower the corneal sensations. I hope you understand this philosophy, yes? That if I feel the sensations when 6 centimeter length of filament is touching my cornea, that means my corneal sensations are intact, absolutely fully. But if I feel sensations at 3 centimeter of the filament distance, that means my corneal sensations are lesser than. I hope everybody clear about the corneal esthesiometer. I don't think anybody will ask you the details of how to do it or how it is done. Usually they will focus on the images, they will ask you to identify the instrument or what is the use of this instrument. That is what the examiners will clinically restrict themselves to. Am I clear, everybody? These are the special investigations which we do in case of a corneal pathology. Part 2 of cornea is done. Now, using the anatomy that we have read and using these investigations, we will start to read the main pathology in cornea, that is part 3, corneal ulcer. What is a corneal ulcer? Most of you will define corneal ulcer as a discontinuity or a break in the epithelium of cornea. That's what you think is a corneal ulcer. But if you say this, I go back to my forensic days and I start thinking about the definition of something called as an abrasion. What is an abrasion, guys? An abrasion is a discontinuity in the epithelium. So if it is a discontinuity in the corneal epithelium, it becomes a corneal abrasion. That's all. It does not become a corneal ulcer. Then is abrasion equal or same as the ulcer? The absolute answer is no. So we have 3 words here. The first word is abrasion. The second word is keratitis. So abrasion is break in the epithelium. Keratitis is inflammation of the cornea. When you combine both, then it becomes a case of corneal ulcer. Okay, everybody? So you cannot just say inflammation of the cornea, you cannot just say discontinuity in the epithelium. You have to combine both to give me the definition of corneal ulcer. So let's see how to define a corneal ulcer, everybody. Discontinuity in the corneal epithelium with cellular infiltration and necrosis of the underlying layers. Okay, that is basically the stroma. The stroma is getting inflamed and infiltrated. Yes or no, guys? Am I clear about this? So corneal ulcer is nothing, if you imagine, but just a wound. Chot lag gayi. Yes or no, everybody? That's called corneal ulcer. Now, when we're talking about corneal ulcer, we are talking about some microbes, everybody, which can lead to the infection. So it can either be a bacterial ulcer, a fungal ulcer, a viral ulcer, and such. So we will discuss them one by one. We start first of all with, everybody, bacterial corneal ulcer, or I will just simply say bacterial keratitis. Even though the words are different, but they are used interchangeably. Now, I will begin with simple etiological questions, everybody. What is the most common cause of bacterial corneal ulcer or keratitis in the whole wide world? The answer is your favorite bacteria, guys, Staphylococcus aureus. When in doubt, mark Staphylococcus aureus. Yes, that is the philosophy we follow in life. Most common cause in India. But in India, we can't follow this Staphylococcus aureus pilosa. The most common bacteria leading to ulcer in India is pneumococcus. So the family changes from Staphylococcus to Streptococcus, Streptococcus pneumoniae. Now, this pneumococcus characteristically leads to an appearance of the ulcer, which we say as ulcus serpens. Serpens means serpentine ulcer. So the ulcer basically starts from the center, then moves towards the periphery in a zigzag sliding movement, you can say, okay, in a serpentine S kind of a shape. Then hypopyon ulcer is the other name for this. Hypopyon corneal ulcer. Pneumococcus always leads to the collection of pus in anterior chamber. That is why the ulcer gets the name hypopyon corneal ulcer. I will show you the image. If you don't know what is hypopyon, if you've never seen an image of hypopyon, this is the image which I would like to show you. Let's see the image here, everybody. You can see the cornea in the center, everybody. And in the periphery, you can see all this sclera conjunctiva which has been congested. Now, if I focus on the cornea, behind the cornea, in front of the iris, between the iris and the cornea, I see this collection of pus. This is known as hypopyon. Am I absolutely clear about this? Then in the center, I see a corneal ulcer. From the center, it will move in a serpentine fashion and it will reach the periphery. So that is why it is called as ulcus serpens, and this is called as a hypopyon corneal ulcer. So this is an image characteristic for pneumococcus. Am I absolutely clear, everybody? Let's move back. Now, some further simple easy questions. What is the most common cause of bacterial corneal ulcer, I'm writing BCU, in contact lens wearers? Contact lens users have a propensity to get corneal complications, obviously, because contact lens is over the corneal surface. So if it is not entirely clean, if it is not entirely sterile, then it can lead to infection. But which bacteria, everybody? The bacteria is now your second favorite bacteria when it comes to gram-negative, that is Pseudomonas. Pseudomonas will cause the corneal ulcer, no specific clinical feature or in terms of shape or presentation, but it always presents with, in the whole body, you will see green color discharge. So the same is true for my cornea also. Always with green colored discharge along with the corneal ulcer in contact lens users, the history of contact lens. Moving on, guys. Most common cause of bacterial corneal ulcer in patients with prior history of LASIK surgery. Now, the point here is LASIK surgery. LASIK surgery, again, if you refer back to our optics everybody chapter, you will know that LASIK surgery is done for myopia, hypermetropia, or any other refractory error. The surgery is doing what, everybody? The surgery is ablating the cornea. That means in any of these refractive surgeries, we are manipulating the cornea. That means there is some kind of exogenous infection which can come into the cornea. So which bacteria is important here? The most common here, the answer is A. Pickle mycobacteria. Okay, so the whole classification, everybody, atypical mycobacteria you should know of: Mycobacterium clinoi, Kansai, Sacrophyllum, whatever it is. Okay. Similarly, everybody, there is a specific bacteria that we need to know of: Nocardia. Nocardia causes a specific shape of ulcer, which we call as wreath-shaped ulcer, or the other name commonly used is known as pinhead ulcers. Okay, let's see the image. What do we mean by a wreath shape, or what do we mean by a pinhead ulcer? What is this, everybody? This is called a wreath pattern. This is a specific arrangement of flowers. You may have seen arrangement of flowers being presented to martyrs during their last rites. Yes or no, everybody? The same kind of presentation we are able to see in the cornea. Yes. Now, in this, you will see that there is an arrangement of flowers. You will be able to see in the periphery. I hope, yes. See, everybody, I'm marking with this. You will be able to see in this. You will be able to see all this, everybody. I can say this, everybody. All this in the periphery. And in the center, there is a relatively clearer area. Yes. So this is likened to a wreath. Now, if we don't understand wreath, then the other name used is pinhead ulcers. Why is it known as pinhead ulcers? If I just circle these small opacities that you see. So I can say peripherally there are a lot of small ulcers arranged. I will again rub so that you can see carefully, everybody. So that is why we either call it a wreath pattern ulcer or pinhead ulcers. I hope we are clear with this. Wreath pattern. Okay, everybody? No confusion about this? Done? Let's move back, everybody. Now, Once we are doing the etiology, there is a very important question about bacterial corneal ulcer which gets asked often again and again. Bacteria which invade intact epithelium. Okay? What are we trying to say? We are trying to say that first of all an abrasion occurs, discontinuity in epithelium. Only after that my microbial agents are able to enter and cause the ulcer of the wound. Yes? But there are certain bacteria which don't need the abrasion, which can enter even an intact cornea and cause the ulcer. So they are more dangerous to us. That's all. So what are the names for this? That's all we want to know. The first important bacteria here is everybody Neisseria. Both the Neisserias, guys, meningitidis as well as gonorrhea. Okay? And the second bacteria is Cornybacterium diphtheriae. Third important bacteria in this list, Listeria. Fourth, Shigella. And fifth, Haemophilus aegypticus. Please remember the names of these 5 important bacteria which are severe as far as the causative agents of a corneal bacterial ulcer are concerned. Am I absolutely clear about this? Done? Once we know about the small etiology, everybody, and the questions asked on it, let's move on to the pathogenesis. Pathogenesis of a bacterial corneal ulcer. Okay? So, stage 1, initial stage. In the initial stage, when the bacterial corneal ulcer has started developing, what you will see? You will see a saucer-shaped ulcer. I hope you understand saucer, everybody. Kind of a dish or a bowl that we eat noodles or stuff in. Yes? So, saucer-shaped ulcer with overhanging margins. In the starting initial stages of any wound, everybody, what do we see? We see a lot of influx of fluid, edema. So due to that edema, the margins will be overhanging along with the saucer-shaped ulcer. If I show you a photograph, everybody, see everybody, this is stage 1. Yes, what are we able to see? An ulcer with overhanging margins due to the edema. Now, the second stage, this is called the progressive stage. In the progressive stage, basically, all the clinical features are agreed, you can say. In the progressive stage, you will see infiltration of polymorphonucleosomes. Am I clear to everybody? So all the inflammatory infiltration is occurring during this stage. Yes? Again, you can see it in the photograph stage 2. You will see the inflammation is increasing. The inflammatory cells are going into the underlying tissue. Yes? When these inflammatory cells are going into the underlying tissue, they can cause what, everybody? They lead to 2 things. Hypopyon. Yes? It is progressive stage leaking inside. Or it can lead to keratouveitis. Along with the cornea, obviously the characteristic hypopyon that we already know of. When I talk about hypopyon, we have already seen the photograph collection of pus in the anterior chamber. Please remember, in cases of bacterial corneal ulcer, 2 words about the hypopyon. Number 1, the hypopyon is thin, so it is mobile. In this stage, you will see that the floor and edges of ulcer, the cause is in. Along with the, if I will turn my head, a collection of pus in the anterior chamber. Please remember, in cases of bacterial corneal ulcer, 2 words about the hypopyon. Number 1, the hypopyon is thin, so it is mobile. So I will say it is a very liquid-like pus. So what do I mean to say by mobile? Look at me, everybody. Let's say right now the hypopyon is in the inferior part. If I will turn my head like this, everybody, yes, the hypopyon will also move along with the movement of my head, and it will now affect this part. If I turn my head like this, now the liquid will move and come in this part. I hope you understand what I'm trying to say. So along with the movement of the head, the fluid will keep on moving as if it is water. And secondly, if we culture this hypopyon, it is absolutely sterile. You will not be able to culture any organism from this. I know it is, the cause is infective, I am not denying that, but the pus itself is not able to give you any culture results. We call it sterile pus. Am I clear, everybody? Done. Now, let's move on to the third stage. The third stage is called as the regressive stage. In this stage, you will see that the floor and edges of ulcer, they become smooth, and you may see some kind of vascularization. in the cornea also. That means the healing has started to occur. Yes, that is why the vessels have come. They are carrying your healing properties. The base and the edges have started smoothing out. That means the whole ulcer has started to fill up. Stage 3. Let's see the image. Everybody, you will see that the inflammatory response is decreasing. Yes, and the ulcer base is becoming smoother. You will see more undulations in the progressive stage and a smoother with less undulations in the regressive stage. Am I clear? Then stage 4. Stage 4 is basically the stage of scar or cicatrization. When healing has occurred, it will leave opacity behind, a scar behind because of the fibrous tissue, and that will lead to permanent visual loss of a certain degree. Okay, so visual loss, which is permanent. I hope you are clear about this. Again, we can see it in the image. This is our stage 4 with some kind of permanent corneal opacity. No confusion about this, everybody. So initial stage, progressive stage, regressive stage, and scar stage. Done? No confusion? Now, based on this, we understand the clinical features and how it progresses. But what can be the complications of bacterial corneal ulcer? Okay, number 1, ectatic cicatrix. Just a fancy word, everybody. Ectasia. Ectasia means what everybody thinking. Yes, what are we trying to say? That there was a corneal ulcer. Okay, let's see. There was a corneal ulcer, due to which the cornea has become thin in this part. Yes, everybody? Now, inside the eye, there is what everybody intraocular pressure. The intraocular pressure is pushing this part out. It may bulge initially, then because of the formation of the scar, it may come back. Whatever may occur. Am I clear, everybody? So there is an ectasia, it is forming a cicatrix, so we are calling it an ectatic cicatrix, as simple as that. I hope I am absolutely clear about this. Due to thinning, bulging of cornea. Okay, it may be temporary or permanent. I hope no confusion about this. Now, secondly, everybody, I use this word anterior staphyloma. Now, what is the difference between an ectatic cicatrix or ectasia and anterior staphyloma? Staphyloma is also, if you remember the lecture on optics again, staphyloma is also bulging due to thinning. Yes, but it is bulging due to thinning along with incarceration of uveal tissue. So see what I am writing, everybody. Anterior staphyloma, bulging of cornea due to thinning along with, I hope you understand the difference here, along with incarceration of iris tissue. Yes, the cornea is bulging, but along with that, some of the iris tissue is coming along with it. So the iris is also getting bulged. So cornea and iris incarcerated together and bulged together, anterior staphyloma. Let's see a photograph, very important photograph here, everybody. I'd like to show you. Let's see this photograph. Yes, what do we see in this photograph, everybody? We see that some of the tissue here has bulged out. It is appearing slightly bluish in color, brownish in color from behind, because the iris tissue is also bulged along with it. One lobule, and then we see another lobulated appearance. Yes, that is what is characteristic of a staphyloma, lobulated appearance. Okay, there is a bulge of cornea with incarcerated iris. Some of the iris tissue is getting incarcerated in this part, some of the iris is getting incarcerated in this part. So that is why you will see a lobular appearance, not a smooth bulge, everybody. Am I clear to everybody? So this is anterior staphyloma. Done? No confusion? Now, let's see, everybody. Complication number 3, desmatocele. From the name itself, it is very clear. Desmato, something to do with Descemet's membrane. Everybody. This is my corneal ulcer. The epithelium is lost, the Bowman's is lost, the stroma is lost. Now, which layer is there, everybody? Descemet's. So let's say this is my Descemet's membrane. The fundamental is the same, the fundamental of pressure, everybody. Now, from inside, IOP, everybody, intraocular pressure, is pushing this part of Descemet's membrane out. So this Descemet's membrane is not able to hold the pressure. So it herniates out. Am I clear to everybody? Herniates through the corneal ulcer. And that is why it's known as desmatocele. Done? Descemet's membrane herniates through the corneal ulcer. Am I clear to everybody? There is no bulging. It is just a herniation, small area. Understand the difference. So this will be like this. I'll just redraw it for you to make it clear. My ulcer was here. This is my Descemet's membrane. This just herniates like this in this small part. You understand the difference between a bulge? Bulge will be of a larger area, all the layers. Here, none of the layers, all the other layers are damaged. Only the Descemet's membrane is herniating out. Desmatocele. No confusion about this? Clear? Let's see a photograph of this. Everybody see this. In this area, everybody, what do we see? That due to the ulcer, the Descemet's membrane has herniated out. A small herniation seen. Descemetocele. I hope there is no confusion. Clear? Done? Now, after all this, everybody, what is going to occur? If my cornea is not able to withhold the pressure in an ectatic cicatrix or in an anterior staphyloma or in cases of a descemetocele, what will occur? Perforation of cornea. So in untreated severe cases of corneal ulcer, this is what is going to occur, perforation of cornea. Perforation, as soon as perforation occurs, what will occur, everybody? First of all, use your common sense, aqueous will leak out, yes or no? Aqueous is responsible for intraocular pressure, that means your eye will undergo hypotony, decrease intraocular pressure. Secondly, everybody, again, if you want a diagrammatic representation, let me try and show it to you. This is my cornea. Behind my cornea is my ciliary body and my iris. This is my iris. This is my ciliary body. Yes? So now, let's say there is a ulcer here. Yes? Due to that, there was a perforation. Now, due to this perforation, what is occurring, everybody? The pressure difference is sucking the iris out. So the iris will get sucked out like this. Am I clear? Due to the pressure, everything will get sucked out. Atmosphere pressure is sucking everything out. So I can say what is occurring here, everybody? Iris prolapse. Am I clear about this? Iris prolapse. Let's see the image. If you don't understand this in a diagrammatic representation, everybody, let's see this. There was an ulcer. The iris tissue has got sucked out, and it has led to the prolapse of iris out of the eye. Iris prolapse. Am I crystal clear? Now, let's see another scenario. I am first giving it a name, pseudocornea. Then I will try to explain it to you. Okay? Okay. Using this figure only. Let's say the perforation was very small. This much. So what occurred? The iris got sucked out. No. The iris, in the process of getting sucked out, got stuck into the surface of the cornea. It was not able to prolapse out. You understand the difference? The prolapse is able to occur only when the perforation is slightly large. If the perforation is small, if it is, the hole is very small, the tissue cannot go out. It gets stuck within the cornea. So now, the surface of the cornea that is visible is cornea, a little bit of iris tissue in the between, and then again cornea. So we say the perforation has been plugged and the corneal surface has been reformed, but it is not a true corneal surface. Yes, there is some part of cornea and some part of iris in it. That is why we call it pseudocornea. Am I clear to everybody? So, corneal surface formed due to plugging of perforation by iris tissue. This is what we call as pseudocornea. Am I absolutely clear? Let's see an image, everybody. Very easy image. This image. Okay. You may find it difficult, I don't know, but if you try to see, this is all the opacity. There was the ulcer. The iris tissue was trying to perforate. You will see a little bit brown part. The iris tissue was trying to prolapse through the perforation, but was caught in the center, and that is why you will see an intact corneal surface. Pseudocornea. Done? No confusion about this? Everybody? No. Lastly, everybody, due to perforation, if nothing is done to treat it, infection will go inside the eye, and it will lead to endophthalmitis, or I can even say panophthalmitis. Okay, if nothing is done to treat the cornea, this is what is going to happen. Clear? That's all about my stages and complications, important ones, of bacterial corneal ulcer. I hope you are all clear. Now, once we know this much, everybody, what is left, everybody? Management of corneal ulcer. Management. Management should involve what? Bacterial corneal ulcer. So if there is an infection, you will give antibiotics. But the question comes, which antibiotics? Will you give broad spectrum antibiotics? The answer is no. That is where the management issue starts from. Okay? So, scrape the base of ulcer with 15 number blade. Send scrapings for grams staining and culture. Antibiotics only after report. So I will say number one. You have to give antibiotics, obviously, yes, but they have to be started only after you're getting confirmed reports of whether the bacteria is gram positive or gram negative, whether it is a cocci or a bacilli. Okay, everybody? Now you will say some culture reports will come in 48 hours, 72 hours, but gram staining report comes in half an hour. You are at least sure of the group of bacteria you are trying to treat, yes? So using your pharmacological knowledge, you will be able to start an antibiotic. Please remember this. Now, normal antibiotics that we get in terms of topical antibiotics, the eye drops, they are not concentrated enough to be able to help in our treatment of corneal ulcer. So we have to use fortified antibiotics. Fortified means the concentration has to be made much more. The usual fortified antibiotics that we use are fortified cefazolin 5% plus fortified tobramycin 1.3.
Fortified.
Okay, everybody? So you have to dilute them, you have to mix them.
Yes.
How to 45. You have to increase the concentration. That is the basic fundamental here. Yes? Done? No confusion? Now, secondly, apart from antibiotics, what is the other thing you have to do? You always have to prescribe atropine eye drops, okay, as supportive therapy to relieve ciliary spasm. Due to the almost always accompanying keratouveitis, there is ciliary spasm which is contributing to the pain. So you have to give atropine. Thirdly, everybody, please remember, steroids are contraindicated as they promote epithelial thinning. Okay, steroids are anti-inflammatory. They will promote epithelial thinning and they will decrease the healing process. We do not want to give steroids. Anyways, we have an ulcer. Anyways, our cornea is thin. If we are giving steroids, we are increasing the chances of perforation. Please remember. Okay. In cases of impending perforation, you have to give oral doxycycline. You can use soft bandage contact lens. BCL, we popularly call them bandage contact lens. They are removable, they're almost like plastic. Just put them and you can remove them after 2 to 3 days if you want. Okay? Or you can use cyanoacrylate glue to stop the impending perforation. That is our management of bacterial corneal ulcer. Everybody, I hope you have been able to understand. Please don't use antibiotics over the counter. Done? No confusion? Now, let's start with the other microbe, that is fungal corneal ulcer. Yes? So, my first question, what is the most common fungi associated with causation of keratitis or corneal ulcer? The answer, everybody, is Aspergillus. Okay? Now, Aspergillus is which type of fungi? Instead of the name, they may give the group filamentous fungi having septate hyphae. With septate hyphae. So, you have to remember this also, the classification. So, they are using a little bit of microbiology and ophthalmology, that's all. Yes? Now, please remember, in cases of fungal corneal ulcer, patient classically gives history of trauma with vegetative material. Now, if you try to convert it into a question, you may have seen if you have done MCQs previously, everybody. The MCQs come something like this. A 52-year-old farmer from Rajasthan gives history of injury with sugarcane 5 days back. Okay? As soon as I hear this, what do I understand? Farmer means working with vegetative material. History of injury with sugarcane means vegetative material. As soon as I hear something like this, farmer and vegetative material, I know it is bound to be a case of fungal corneal ulcer. Yes? Am I clear about this? Done? Now, very importantly, everybody, once we know about this, we should know that the signs in cases of fungal corneal ulcer. As soon as I hear this, what do I understand? Farmer means working with vegetative material. History of injury with sugarcane means vegetative material. As soon as I hear something like this, farmer and vegetative material, I know it is bound to be a case of fungal corneal ulcer. Yes? Am I clear about this? Very importantly, everybody, once we know about this, we should know that the signs in cases of fungal corneal ulcer are out of proportion to the symptoms. That means the patient will say, sir, I don't have a lot of pain. There will be minimal redness. There will be minimal irritation. But when you will examine, you will see a fulminant ulcer already being formed. So the patient is not coming due to the symptomatic problem. The patient is coming because he can see some kind of wound or ulcer being formed in the eye. Yes? So what are the signs, everybody? Let's focus on the signs. Number 1. First of all, dry looking ulcer. This is something which you understand with experience, whether the ulcer is dry looking or is it wet and glistening. Okay, this is not something which I can teach you theoretically, basically. Secondly, everybody, feathery margins of ulcer. Important diagnostic point which you can see, everybody. What do I mean to say? Let's say this is my ulcer. One ulcer can be like this, a completely circumscribed with smooth edges. Or I am saying the ulcer in cases of fungi is like this, with irregular margins which look like the feathers of bird. Yes, feathery margins of ulcer. Third important sign, everybody. Satellite lesions. What do I mean by satellite, everybody? What is moon to earth? That is what is a satellite. Yes. So, along with the main ulcer, you will see some small ulcers in the periphery. So, we call them satellite lesions. As simple as that. Then, everybody, another important feature is Wesley immune ring. Okay. So, what is Wesley immune ring, everybody? ring of immunity antigens from the wound antibodies, they are colliding at one place and they are visible as a faint ring. Okay, so around the ulcer, you will be able to see a faint ring of antigen antibody complexes, and that is called as Wesley immune ring. Okay, lastly, everybody, hypopyon. Hypopyon or pus in the anterior chamber, we have again seen a lot of photographs already. Yes, but how to differentiate a hypopyon of bacterial corneal ulcer from a hypopyon of a fungal corneal ulcer? I hope you remember the bacterial corneal ulcer hypopyon was mobile, but in this case, it is immobile. The pus is thick. So because of the thick pus, if you will move your head to the left or the right, the hypopyon will not move. It is almost stuck at the inferior portion of the cornea, immobile, and it is asterile. That means you will be able to culture the microorganism from the hypopyon sample. Am I clear, everybody? So two characteristic differences between bacterial hypopyon and fungal hypopyon, right? Now, you've seen that I made a diagram here of the fungal corneals. If you've understood this, along with the clinical features, you will be able to see all the same things in the image that I'm going to show you next. Let's see this. Yes, in this image, what are we able to see? First of all, you see the ulcer in the center, and you will be very easily able to see that it does not well circumscribe, it does not have any smooth margins. Yes, feathery margins of the ulcer. No confusion about this. Then, if we focus, we are able to see this small satellite lesion also. So I'm marking this as a satellite lesion. Okay, everybody? Then if I again focus, everybody, I'm able to see this faint ring of immunity. Am I clear to everybody again? So this is my Wesley immune ring. No confusion here, everybody? Yes, the only thing which we are not able to see here in this photograph is a hypopyon. If a hypopyon was present, you would have seen pus here. Yes, so this would have been a hypopyon. So all the characteristic features of fungal corneal ulcer, why am I showing them to you in an image? As soon as an image comes, you should be able to diagnose without any history, without anything, that it is a case of fungal corneal ulcer. Please remember, along with that, the history of trauma, it will make your job easy. Right? Now, once you've been able to diagnose it, everybody, let's treat it. So obviously, to treat it, we will have to give antifungals. No brainer, everybody. Which antifungals to use? Natamycin, 5% eye drops. These are the drugs of choice, you can say, because they can be used in cases of filamentous fungi, which are the most common cause, that is Aspergillus and Fusarium. But in case you have a Candida infection, you can go to amphotericin B, 0.15% drops. Please remember, atropine is used as supportive therapy, just like in cases of bacterial corneal ulcer. And again, just like in bacterial corneal ulcer, due to the fundamental of perforation and the risk rate, steroids are contraindicated. Then everybody, no confusion, I hope everybody, that's all about our fungal corneal ulcer. After this, we'll move on to the third microbial agent, that is viral corneal ulcers. Continuing with corneal ulcer, everybody, bacterial, fungal, viral done. So now the new agent that can cause is Acanthamoeba keratitis, small topic in itself. Now, we have heard Acanthamoeba ulcer, Acanthamoeba keratitis various times, I hope, along with the word contact lens users. Yes? So that is the first point that we need to discuss here. What are the risk factors which lead to Acanthamoeba keratitis? The most important risk factor is contact lens use. Okay? But this is where the dichotomy comes. I also told you in bacterial corneal ulcer that the most common cause of bacterial corneal ulcer in contact lens users is Pseudomonas. Then if such a question is asked, what should you answer? Acanthamoeba or Pseudomonas? See, that is where the difference is. If somebody is wearing contact lenses, then the person is more bound to get Pseudomonas ulcer. But if you are wearing contact lenses and you are not cleaning them properly, that means contact lens use with contaminated solution, the solution in which the contact lenses are kept, or if contact lens is washed with tap water. In such cases, the answer changes and it becomes Acanthamoeba. Are you getting what I'm trying to say here? Done? Clear? Secondly, Acanthamoeba keratitis can also be acquired if you are a fool. What do I mean to say by fool? If you are wearing your contact lenses and you are going swimming. So any problem with water basically is leading to Acanthamoeba keratitis. So sometimes we also call it swimming pool keratitis, though that name is not very commonly used. So just remember this, dirty water Acanthamoeba along with contact lenses. Done, everybody? No confusion about this, I hope? Now, what are the clinical features? So please remember, it is opposite to fungi. It is opposite to fungi in the terms that in fungi the signs were out of proportion to symptoms. But here the symptoms are out of proportion to the signs. So the patient complains of severe pain. That is usually why the patient has come to you, because of severe pain. And now when you are looking at the signs, you will see that the signs are very less compared to the degree of pain that the patient is reporting. So what are the signs? Number one, pseudodendritic keratitis. Already explained to you in herpes simplex and herpes zoster, told to you in the differential dendritic ulcer. Second important sign is known as radial keratoneuritis. Again, if you focus on the English, it is self-explanatory, everybody. Radial means 360 degree, keratosis means cornea, and neuritis means inflammation of nerves. So inflammation of nerves throughout the cornea, that is leading to the severe pain. I hope you understand this. And then thirdly, you can say almost diagnostic or pathognomic is the formation of a ring-shaped abscess. Ring-shaped abscess. Everybody, very easily discernible on a photograph. You will be able to see in this image that I've shown you on the bottom of the screen that there is a ring-shaped ulcer with some kind of pus collection in it, which is called an abscess. So this is a ring abscess. I hope I'm clear. No confusion about this? Done? So these are the 3 diagnostic clinical features of a case of acanthamoeba keratitis. Now, once we have diagnosed the clinical features, we need to confirm the diagnosis. The diagnosis can be confirmed via Gram's staining. When you do Gram staining, what are you able to see? You are able to see these double-walled acanthamoeba cysts. Okay, everybody? Or if you want to culture, what is the culture media, everybody? That is the question which is asked in microbiology also. Please remember, non-nutrient agar enriched with E. coli. So that's a culture media. Done? Am I clear? So we have seen the clinical features, we have confirmed our diagnosis by staining and by culture. Now we need to do the treatment. So let's see what is our treatment. Number 1, drug of choice. Drug of choice is something called as PHMB 0.02%. What is PHMB, guys? This is polyhexamethylene biguanide. PHMB, polyhexamethylene biguanide. Okay, please just write the name. The another drug, second, that we can use is chlorhexidine 0.02%. Both these drugs have the same mechanism of action in the fact that they will inhibit membrane synthesis. But if you actually ask me clinically, none of these 2 drugs is commonly used. Clinically, what we commonly use is propamidine. Okay? Propamidine acts by another mechanism, that is inhibition of the DNA synthesis. Am I clear, everybody, about this? Yes? Even though the drug of choice is PHMB, PHMB is not available at all. Very, very, very rarely you are able to find PHMB. So clinically, we end up using propamidine. This is the most commonly available, easily available, and used drug for acanthamoeba. But nonetheless, if a question is asked theoretically, you have to go with PHMB 0.02% as the drug of choice. That's a small topic on acanthamoeba keratitis. With this, we finish the 3rd topic of the cornea, that is corneal ulcer. Please remember, first of all, keratitis, aberration, and ulcer, the difference between the 3 words, and then different sets of microbes. Bacterial, all the images I've shown you. Fungal, the single important image. Herpes simplex virus, the important topic in which steroids are used or not used, what are the epithelial, endothelial, blah, 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 and acanthamoeba keratitis. Are you clear about this, guys? Done? So now let's start with viral keratitis. 3rd topic, bacterial done, fungal done, viral. In viral, obviously the main virus that we are trying to discuss here is the HSV, herpes simplex virus. Now, HSV will cause infections in the eye, but as a primary infection, it will usually affect the conjunctiva. So in the primary infection, we are expecting conjunctivitis to develop. Okay? When there is a recurrent episode, then keratitis develops. This is usually what occurs, not the rule. Yes? We are about to discuss here keratitis. Now, so what are the clinical features of the presentations in terms of keratitis when caused by herpes simplex virus? So number 1, we say epithelial lesions. Herpes simplex virus can affect any level of the cornea, epithelium, stroma, or endothelium. Yes? So we need to be able to differentiate between the different types of lesions based on the layer affected. So what I'm discussing here is epithelial lesions. Epithelial lesions can present in 3 forms. Let's see the photographs and understand from them. A. What do we see in this image? We see number 1, fluorescent staining, that we already know, green colored staining. Throughout the cornea, we get a stippled appearance, a dot-like appearance scattered throughout the cornea. This presentation is known as superficial punctate. As I mentioned previously in other lectures, punctate means dot-like. So that is the word we use for dot-like lesions, punctate. Superficial punctate keratitis. Okay, only SPK. Now, if it progresses, it will turn into this characteristic lesion, second lesion. Can you name this characteristic lesion, everybody? I hope yes. This is called as dendritic ulcer. Yes, you must have heard of this name. If not, then please understand, it is a branching ulcer just like a dendrite. So it is branching in different directions. Okay, if you see it microscopically, you will be able to see small terminal buds. At the end of each branch, you will be able to see small elevations, very small elevations. You cannot make it out in this photograph. It has already been stained with fluorescent dye, so the dye is filling everything. Yes, but at the end, we see terminal buds. These are the locations where the virus is being carried, and that is why the ulcer is getting progressed. Dendritic ulcer. If dendritic ulcer will progress further, all these branches will join together, and you will get a large ulcer, which will look like a map of a country or a state. And that is why this 3rd epithelial lesion gets the name geographic ulcer. I hope I'm clear here. You will be able to see if I draw the outline. This is the ulcer. So all the dendritic edges have joined each other and it has created a large ulcer for us. Am I correct, everybody? Looking like a map of something. Geographic ulcer. These are all three epithelial lesions in continuation with each other. SPK, then dendritic, then geographic. No confusion about this? Now, if you ask me what is the treatment of epithelial lesions, then I will ask you to apply common sense. It is a viral lesion. So obviously I will use antivirals. But the question comes with antivirals. Obviously 3% acyclovir eye ointment. Okay, it has to be applied 5 times per day for around 10 to 14 days. This is the regimen which is usually followed. This is an epithelial lesion, so the fundamental of the bacterial and fungal corneal ulcer will be applied here. If it is an epithelial lesion, if I give steroids, it will lead to thinning, it will lead to perforation, it will lead to inability to heal. So again, we say in all epithelial lesions, steroids are contraindicated. So please remember the steroid part, and please remember acyclovir. I have not written oral. I have specifically written ointment. Am I clear to everybody? No confusion? Done? So in all the three, so SPKs, dendritic ulcer, and geographic ulcer, the treatment will remain the same. Now, a question comes. What is the differential diagnosis of a dendritic ulcer? That means which other lesions can resemble a dendritic ulcer? So, acantha amoeba, keratitis. It does not cause dendritic ulcer, it resembles like that. So, differential diagnosis. Secondly, herpes zoster virus keratitis, HZV. Thirdly, everybody, tyrosinemia. Okay, everybody? Tyrosinemia can also give corneal lesions which resemble my case of dendritic ulcer, or the overuse of contact lens. These are some of the important differential diagnoses that you need to remember when you are examining a case of herpes simplex virus keratitis. Am I clear, everybody? Also remember about epithelial lesions, that all epithelial lesions are due to active viral replication. So we need to know the three lesions, the treatment, and what is the cause? The cause is active viral replication. Now we move on a little deeper into the cornea, guys. We move on to the stromal keratitis. Now, epithelium is not getting affected. The layer of cornea getting affected by herpes simplex virus is the stroma. Okay? When stromal keratitis occurs, this is the usual first presentation that we get. What is this, everybody? This is the usual first presentation that we get. What is this, everybody? This is known as ISK, or I can call it immune stromal keratitis. Stromal keratitis usually does not occur primarily as a corneal complication of HSV. You will see that first of all, some epithelial keratitis must have occurred. It has resolved, and then after some time, the stromal complications of the stromal keratitis lesions have developed. By the name immune, you understand that they are developing after some time when there is antigen-antibody reaction. Yes? So we say this is due to type 3 hypersensitivity. Okay? And it is almost always occurring after epithelial keratitis. Now the image is here. You must be wondering, what are you able to see in the image? So the image, you will be able to see a central, now focus very carefully, everybody, a central small stromal haze. So we say we are able to see a central stromal haze. Am I clear, everybody? Immune stromal keratitis. What is the treatment of immune stromal keratitis now? Everybody. That is where the difference comes. Obviously, first of all, you will have to use 3% acyclovir eye ointment. It is also viral. But along with this, because now the epithelium is not affected, topical steroids are also used. Am I absolutely clear here? Yes, epithelium is not damaged, so steroids cannot cause thinning, blah, blah, blah. So to control the inflammation, we are using steroids also here. Moving on, everybody. Second lesion in the stroma, necrotizing stromal keratitis. I hope the name is self-explanatory. This is the most severe form of stromal keratitis where necrosis occurs, destroying all the stroma and the underlying tissue. The treatment will remain the same. Okay, everybody? Acyclovir along with topical steroids. No confusion, I hope. Now, let's move deeper. From the stroma, now let's see what will happen when there is an endothelial lesion. So the endothelial lesion which occurs is known as disciform keratitis. Disciform keratitis. Disc-eye form. From the name itself, it is very clear that you will see disc-shaped lesions affecting the endothelium. Okay, so disc-shaped areas of deep stromal / endothelial edema. See, only endothelium is not affected. A little bit of the adjoining deep stroma is also affected. Okay, but this does not get classified as a stromal lesion because the primary site is the endothelium. This gets classified as an endothelial lesion. Please remember, this is a type 4 hypersensitivity reaction to herpes simplex virus. Okay, everybody? Done? No confusion? So these are the 3 levels of the lesions. Obviously, the most important are epithelial lesions. Please remember the use of steroids can be done in everything except the epithelial lesions due to herpes simplex virus. Okay. After having said all this, everybody, I will put a double star and I will write what is the hallmark of HSV keratitis. If we remember the basic anatomy where we had discussed the layers, the nerve supply, we should remember corneal anesthesia. Corneal anesthesia is the hallmark. Yes, there is anesthesia. You touch the cornea, the patient will not be able to breathe. Due to this, there occurs something known as metaherpetic keratitis, or also known as neurotrophic ulcer. Am I clear, everybody? Because the patient cannot feel anything. So even when the eye is open and something dust and everything is falling inside the eye, the patient is not able to feel anything. So neurotrophic, due to degeneration of the nerve, some ulcer is occurring in cases of herpes simplex virus. So if somebody asks you neurotrophic ulcer is due to, what will you say, everybody? Due to fifth cranial nerve palsy. I hope I am clear here. Yes, what is the nerve supply of the cornea? Fifth cranial nerve. Corneal anesthesia means fifth cranial nerve palsy. Yes, done. That's all about herpes simplex virus. Please remember all these images that I've shown you and simple points that I've explained to you to be able to solve all the questions. Now, moving on to the other virus, herpes zoster, causing herpes zoster ophthalmicus, or what we popularly call as shingles. Okay, everybody? Now, what we need to know is herpes zoster ophthalmicus or shingles usually affects the dermatome supplied by ophthalmic branch of fifth cranial nerve. Am I clear, everybody? So all this area, this gets affected. Where what occurs, everybody, as you can see in the image, rash. Okay. Now, if the rash affects the tip of nose, as is getting affected in this image, tip of nose, then the chances of HZO are increased. And this phenomena is known as Hutchinson's sign. I have no confusion, everybody here. Am I absolutely clear? There should be no confusion. If the tip of nose is affected, then you know that the eye will be affected. If not affected, then the chances of ophthalmicus occurring. What are the presentations, everybody? Clinical features, let's see. Number 1, pseudo-dendritic ulcer. As we discussed in the differential diagnosis of dendritic ulcer, something like a dendritic ulcer can occur in HZV also. So what is pseudo, everybody? Again, it will be a branching pattern, but there are no terminal buds. That is why it is called as pseudo-dendritic ulcer. Okay, absolutely clear? Now the second important lesion that occurs is known as nummular keratitis. This can occur in other viral infections also, but in herpes zoster virus, it is seen very commonly. Now in this photograph, what you are able to see? You are able to see coin-shaped lesions. Yes? Are you able to see coin-shaped lesions? These coin-shaped lesions denote nummular keratitis. So coin-shaped subepithelial lesions. Nummular keratitis. Am I absolutely clear about this, everybody? No confusion? Then what else can occur, everybody? Number 3, mucus plaque keratitis in chronic cases. Number 4, everybody, just like herpes simplex, stromal keratitis can occur. Number 5, everybody, it can even lead to cranial nerve palsies. A lot of cranial nerve neurological complications can occur, cranial nerve palsies can occur. The most common nerve affected is the third cranial nerve. Then please remember that if they ask you what is the least common ocular sign caused by herpes zoster virus, then the answer will be sclerokeratitis. Okay, just remember this is a straight one-liner MCQ if somebody wants to ask you, even though the era of those kind of MCQs is now probably over, guys. Okay, number 7. Another important sign is post-herpetic neuralgia. Post-herpetic neuralgia, that even after 1 month of resolution of HZO, pain persists. And this pain is usually worse at night. So you have to inform the patient about this, that even though your lesion is treated, but in this area the pain may persist, post-herpetic neuralgia. Now, what is the treatment, everybody? The treatment is simple. Tablet acyclovir, 800 mg, 5 times a day for 2 weeks. That is the treatment of herpes zoster ophthalmicus. Am I clear, everybody? No problem? Done. that we're done with our part 3 of cornea, guys. Let's start with the part 4, the last part, miscellaneous conditions. I'm calling them miscellaneous not because they are not important. I'm calling them miscellaneous because they are just single topics which I can't group in anyone, right? So the first miscellaneous topic that I'll do is corneal dystrophy. Corneal dystrophy is a topic which students usually don't study in their MBBS days and neither in the pre-PG preparation days usually. I will not say that this is a very commonly asked topic, but yes, it is asked. It's not that it is not asked at all. So I will be discussing it in brief and I will be trying to tell you some images and how you have to see them or how you have to diagnose them, right guys? So first of all, what we need to understand about corneal dystrophies, guys, is that dystrophies are primarily corneal diseases. That means they straight away affect the cornea. They are not manifestations of some systemic disease or blah, right? They present usually in the first to second decade of life. Now, also what you want to know about corneal dystrophies is they are dystrophies. So I can say they are non-inflammatory, yes? Then they are always progressive. The dystrophies will keep on affecting larger areas of cornea as we move ahead. They are usually bilateral and the inheritance pattern in corneal dystrophies is autosomal dominant. Okay, so these are 5 characteristics you can say about all corneal dystrophies. They're primary corneal disorders which are non-inflammatory, progressive, bilateral, autosomal dominant, and they present in the first to second decade of life. Now, below this, once we know this, once we learn this, there's a table of all the names of the corneal dystrophies. See, there are lots of names. That is why we don't read it. So what I've tried to do is I've tried to simplify it for you as much as possible. The dystrophies are classified based on the layer that is being dystrophy. So as you will be able to see epithelial dystrophy, Bowman's layer dystrophy, stromal dystrophy, or endothelial dystrophy. Okay, let's look at one by one how to learn this, how questions are asked, and we'll keep moving on from there. Let's first of all see the epithelial corneal dystrophies. There are 3 main epithelial corneal dystrophies. You can remember the name by the mnemonic CML. Everybody, the tumor chronic myeloid leukemia, CML. That's how I remember these 3. So C for Cogan's epithelial basement membrane dystrophy. The most important point about this is the question that will be asked, it is the most common. Now I am not going to describe the clinical features and everything of all the corneal dystrophies. A lot of corneal dystrophies, even though they are present, they don't cause any symptoms or they are not important or we do not see them commonly. So I'm not going to discuss each and every corneal dystrophy. Cogan's, even though it occurs, the patient can pass the whole life without any sign being visible or without any symptom being experienced by the patient. Nothing to discuss. Okay, Cogan's is the most common. That's it, period. Done. Now the second is Meesmann epithelial dystrophy. Meesmann, the first question, the difference from all the corneal dystrophies that we know, they should be progressive, but as is written here in one word, this is non-progressive. Yes, and this is specifically due to the mutation of a gene, which is marked here for you, keratin gene mutation. Now, due to this keratin gene mutation, the clinical appearance which occurs is characteristic. So I will show it to you, everybody. So this is a photograph of Meesmann corneal dystrophy. What are we able to see, everybody? Don't go on the red color. This is a photograph of the cornea clicked against the red glow of the fundus. Yes, focus in this part, everybody. What are you able to see in this part? You are able to see some microcysts, very small cystic lesions. Yes, in the corneal epithelium. Okay, these microcysts contain some substance which is due to the keratin gene mutation. That substance is unknown, but yes, these cysts are formed due to the accumulation of that unknown material due to keratin gene mutation. This is Meesmann's corneal dystrophy, the image, and the 2 simple important questions that we asked. Right now, let's move back, everybody. The last is called as Lisch epithelial dystrophy. Again, please remember that apart from autosomal dominant, it can also be X-linked dominant. Nothing else is of significance here. Now, the second group of corneal dystrophies, Bowman's layer. 3 Bowman's layer dystrophies. You can remember them by the alphabetical order. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T. I hope you understand. R, S, T alphabetically. So Rees-Buckler's dystrophy, Schneider central crystalline dystrophy, and Thiel-Behnke dystrophy. These are the 3 important Bowman's layer dystrophies. Nothing much to discuss about them. Just remember whatever is written here. Though still I think nobody will ask you this, so I'm not going into the detail. Now coming on to the third dystrophy, that is the stromal group of dystrophies, which is the most commonly asked topic. Yes. So number 1, L. L for lattice. I don't have any mnemonic for you to remember this. You'll just have to remember it like that. Lattice corneal dystrophies can be of 3 types, as you can see, type 1, type 2, type 3A. Whatever the dystrophy may be, in all the lattice dystrophies, the deposits of amyloid are seen within the stroma of the cornea. So to diagnose them, basically what we are trying to see, we are trying to see amyloid deposited within the corneal stroma. Yes. Now how do we see amyloid? We can either see it by PAS stain or we can see it by the Congo red stain. So let's see, everybody. This is a photograph which has been given to you. This is obviously which stain, everybody? Periodic acid shape stain. You can see an amorphous pink deposit here. Yes, this denotes amyloid. Or the better diagnosis is by Congo red stain. I hope you can see Congo red stain. Congo red stain, amyloid. I hope you remember from your pathology. Will give what, everybody? Will give an apple green bifringence. Yes. So these areas, everybody, you can see these are all amyloid deposits after getting stain on Congo red stain. Yes, thus making our life very easy, and we are able to very easily diagnose these as a case of lattice dystrophy. So that's what I'm trying to say. let's be smart. Let's not go into the details. Let's just try to learn here what the examiner is most likely to ask us. Yes? So deposits of amyloid in all the lattice corneal dystrophies, stained by Congo red stain, apple green birefringent lens, C. Now, if you want to nitpick everybody, if you want to go into the details, what are the other questions which can be asked? Please remember that in lattice type 2A, neuropathy is C. Please remember that lattice type 2 presents in the age group 70 to 90 years. Usually the age of presentation is first to second decade. So if they want to ask you a sort of a question which says which corneal dystrophy occurs in old age, then the answer will be lattice corneal dystrophy type 2, which is also known as Finnish corneal dystrophy. If they want to ask you another question, they ask you lattice corneal type 3A instead of autosomal dominant is autosomal recessive. I don't think they will ask you this, but still the information is written for you here. Now, let's move on to another important dystrophy. Gelatinous, just remember the name. Now, another important dystrophy here is granular corneal dystrophy. From the name, we understand that the appearance must be in the form of some granules. You will see the photograph. And then what is written here is that there will be what kind of deposit in type 1, everybody? Hyaline deposit. There will be what kind of deposit in type 2, everybody? Again, hyaline plus amyloid. What is common to both, everybody? Common to both granular is hyaline. So please remember, granular is equal to hyaline deposit. So to diagnose, we want to see hyaline deposit. Now, hyaline deposit is seen by which stain? The answer is Masson trichrome stain. Okay, let's see the image, everybody. So this is an image of Masson trichrome stain. What we can see, first of all, the epithelium with all the nuclei in it, all this collagen in blue color being stained. But within the stroma, where there is blue collagen, we are able to see these pinkish yellowish deposits everywhere. Everybody? So these are hyaline deposits. These are all hyaline deposits. So, hyaline deposits. I hope I'm clear. The stain is Masson trichrome, and the diagnosis becomes granular dystrophy. No problem. Now we are saying granular dystrophy, granules. So what is the appearance like? So it is a very easily discernible dystrophy on slit lamp. We are able to see breadcrumb-like granules which are separated by clearly demarcated spaces in cornea. Okay, so you will see as if breadcrumbs are deposited throughout the cornea and the intervening spaces are absolutely clear. Okay, this is a characteristic photograph of granules on the cornea, granular corneal dystrophy. I hope I'm clear about this. There should be no confusion in this. Yes, guys, no confusion about this. Done. Let's move back into it. Now, another important dystrophy is M for macular. This is important because this is autosomal recessive and this is the least common corneal dystrophy. Am I clear, everybody? Autosomal recessive and the least common. Now, what gets deposited in macular corneal dystrophy? So, in macular corneal dystrophy, what is deposited is acid mucopolysaccharidosis. Okay, so acid mucopolysaccharides are getting deposited. So, this is a form of acid mucopolysaccharidosis. This has been stained by Alcian blue stain. And upon staining with Alcian blue stain, what we are able to see, everybody, all the stromal collagen fibers has pink. But this is a deposit of acid mucopolysaccharides. Yes, giving us the diagnosis, very easy, very clear, that is macular dystrophy. Done? So what is important if you see? Let's just see again, everybody. First of all, we need to remember the name of the dye. So Masson trichrome for hyaline. Then we need to remember hyaline deposits are seen in granular image. Again, see, Congo red means what, everybody? Amyloid means apple grain birefringent lens. And similarly, lastly here we see acid mucopolysaccharides by Alcian blue stain. The answer is macular dystrophy. Am I absolutely clear, everybody? So, deposits of what in which type of stromal dystrophy and then the respective histopathological images. I hope I'm clear. Lattice, granular, macular. Please remember. Now, moving on to the last group of corneal dystrophies, that is endothelial, everybody. The important is Fuchs endothelial dystrophy. From the name itself, it is very clear that the endothelium is getting affected. Yes? In this, there is a mutation of the gene which is called as COAX2 gene. COAX2 gene mutates, which leads to damage to Descemet's membrane and a little bit of endothelium. Due to the mutation of COAX2 gene, the Descemet's membrane and the endothelium get damaged. Due to that, the function of the endothelium and Descemet's membrane of the fluid entering the cornea is improper now, which leads to wart-like excrescences formed on the endothelium. Or, if I try to explain it to you through a photograph, see, everybody, this is my stroma here, should be no problem. This is my endothelium, which should be a smooth line. But now, there are clumps of cells, which are appearing as wart-like excrescences. Okay? So there will be these wart-like excrescences, then there will be these clear spaces in between. Okay? This is known as cornea guttae. These are known as corneal guttae, and these are what are diagnostic of Fuchs endothelial dystrophy. Am I clear to everybody? There should be no confusion about this. That is the word written here, cornea guttae, wart-like excrescences. Done, everybody? Then there are two others, posterior polymorphous corneal dystrophy and congenital hereditary endothelial dystrophy type 1 and type 2. Done? No confusion, I hope, everybody? Please just learn these important facts that are written in this table and simple photographs, 7 photographs that I've shown you along with simple explanations. Now, there are two other questions which can be asked pertaining to corneal dystrophies. What are the causes of recurrent corneal erosions? What of these conditions can lead to corneal erosions? Obviously, because cornea is getting damaged, which are recurrent again and again and again and again. The mnemonic for this is CTRL1. CTRL is the control key on your laptop or your computer, guys. Yes. So C for Kogan, T for Thiel-Behnke, R for Rees-Buckler, and L1 for lattice type 1. Okay, everybody? So if you will see the table, you will again be able to see Kogan, Thiel-Behnke, Rees-Buckler, and lattice type 1. The second question is, what are the disorders of metabolism? So kind of list-based questions if examiners want to ask you. Disorders of metabolism. Even though it is written in the table, I'm just giving you the mnemonic again here, MMS. MMS. Let's go back to the table and let's see MMS, everybody. M for, first of all, Meesmann, right? Keratin gene mutation. Then M for, again, everybody, macula. And then S for, everybody, Schneider central crystalline dystrophy. MMS. Okay? Meesmann, macular, and Schneider. These are the three causes of the corneal dystrophies due to metabolic disorders. No confusion about this? Am I clear? Done? That's all about metabolic corneal dystrophy. If you ask me, what is the treatment of corneal dystrophy? See, these are dystrophies. That's all about corneal dystrophies. So after finishing corneal dystrophy, continuing with our miscellaneous disorders, one of disorders, very important disease in itself, that is called as keratoconus. Okay? From the name itself, I hope it is abundantly clear. We are talking about a cornea. Kerato means a cornea, and conus means something which is cone shaped. Yes, this is non-inflammatory again. As a pathology, this is non-inflammatory and almost always progressive. And by virtue of forming a cone, it is classified as an ectasia. Ectasia means something which is causing the corneal thin. Okay? If you don't understand it in simple words, let's just see a simple image. Let's just draw it. Let's say this is my normal cornea, which is convex. If there is shape abnormality occurring, wherein the convex shape is slightly becoming coned out, we will call it keratoconus, as simple as that. Okay, everybody? Now, what are the important etiological factors, so as to say? Usually we say it is congenital, inherited. Okay? Congenital weakness of the cornea, which is leading to the thinning and thus the formation of the cone. Or we see it is commonly associated in cases of trauma, very commonly associated in cases of VKC, vernal keratoconjunctivitis. I hope spring catarrh, you know, in conjunctiva due to constant itching and rubbing. See, when I'm constantly itching or rubbing something, I'm providing force for the shape to become abnormal. Yes. And then lastly, it is also seen to be associated or seen in children suffering from Down syndrome. Now, what are the clinical features? Number one, please remember that the patient presents with visual disturbance. Why will there be visual disturbance? Due to myopic astigmatism. Why will there be myopic astigmatism? Please understand, everybody. Everybody, as soon as I have a cone, everybody, my axial length is increasing by some distance. Yes. If this was my normal eye, let's say, this was my normal axial length, when I have keratoconus, my axial length is increasing. Yes. Plus my corneal curvature is increasing. So axial length increase as well as corneal curvature increase both lead to myopia. The vertical curvature is changing, the horizontal curvature is not. So both the curvatures are different, so it is leading to astigmatism. So that is why I am having myopic astigmatism. You will be able to understand this only if you have read optics chapter, otherwise you'll have to go back to optics. Yes, no problem. It's very good. Now, secondly, everybody, if we say what is the hallmark, so on examination on a slit lamp, we see central or slightly around the center, paracentral stromal thinning, okay, which is always inferior to the center. Am I clear to everybody? Yes. So the thinning will slightly be inferior to the center. So the cone is always in the inferior part of the cornea. Then, thirdly, the diagnostic sign I can say on torchlight, which a lot of you may have seen or examined in your clinical postings, everybody. See, the word is clinical. This is a case. You have to examine it. Munson's sign. What is Munson's sign, everybody, if I ask you? This is bulging of lower lid on down gaze. If you understand the fundamental of shapes, you understand this. Let us see how or what I'm trying to tell you. Let's say this is my cornea. Let's say this is my upper eyelid. And let's say this is my lower eyelid. Okay, everybody? My cornea, behind that my whole eyeball. Okay. My cornea is convex. So is my curvature of the lower eyelid convex. This is my lower eyelid. Now, when I will look down, everybody, my eyeball will roll down. Convex structure like a ball, which will roll down and it will go below, or it will be able to turn below the lower eyelid. But let us see what will happen in the case of keratoconus. This is my upper eyelid. This is my lower eyelid. But my cornea is slightly cone-shaped. Can you see, everybody, cone-shaped? Now when you try to look down, what will occur, everybody? This cornea, now I'm drawing it with green color. this cornea will roll down in such a place that the edge will get stuck over the eyelid margin. Yes? The edge of the cone is getting stuck over the eyelid margin. So when you try to look more down, the eyelid will also be pushed down. Am I clear to everybody? If you don't understand it trigonometrically, let's see an image. In this image, you don't understand the mechanics of how it works. But see, again the same thing. The apex of the cone has got stuck over the lower eyelid margin. And that is why it has pushed the lower eyelid also down into a bulge. Moon, sun's sign. Okay? Just see this image. And if you want to compare it, see yourself in the mirror and see how your eyeball will go down. Right? No confusion about this. So this is an image of Munchausen's sign. Moving on, everybody. Let's see another important sign. Sign number 4. We call it Rizuti's sign. Okay, what is Rizuti's sign? Rizuti's sign is arrowhead of light seen over nasal limbus when light thrown from temporal side. Am I clear? Let's see the image. This is a case of keratoconus. When we are throwing light from the temporal side, what is happening, everybody? The light is getting reflected or refracted, you can say, from two angles or from two kind of, you can say, slopes. One superior slope, one inferior slope. So one light and second light going like this. So the light comes here, gets refracted, forms an arrowhead of light over the nasal. This is called as Rizuti's sign. Okay, am I clear, everybody? Next, please. Sign number 5. On ophthalmoscopy, we see something which is called as oil droplet reflex. Very easy to understand, guys. The cone will throw a shadow. When you're trying to look at the fundus, the apex of the cone will throw a shadow in the form of a circle, and that is known as oil droplet reflex. Everybody see this? Because there was a cone, the apex of the cone is throwing a central shadow over the cornea, and this is known as oil droplet reflex. Done? No confusion about this, I hope everybody clear? Yes? Now, moving on, everybody. Sign number 6 on retinoscopy. Something called as the scissoring reflex is seen. I know you like to see the photograph of this, but this is not at all identifiable in a photograph. This can only be seen in a video, everybody. I don't personally have a very good video of a scissoring reflex. I have not been able to record it, guys. Please just learn this name. Number 7. Due to the thinning of the cornea, there develop small fine breaks within the corneal stroma, which are known as Vogt's striae. Am I clear to everybody? No confusion? So, stromal stress lines, I can call them. Fine breaks. Now, once you know the clinical features, what is the investigation of choice? Everybody think about the special investigations we have discussed. Keratoconus is cone shaped. That means it is an abnormality of shape, abnormality of surface. So which investigation should be used? Keratometry or pachymetry or topography? I hope the answer is clear to you. There should be no confusion. The answer is corneal topography. Okay, done? Clear? Now, after this, we should know the treatment. Number 1. The easiest treatment that you can do is rigid contact lens. Rigid contact lens, not the soft contact lenses that we usually wear for our myopias. There is a cone in the cornea. When I put a rigid contact lens over it, this will put pressure over the center. It will lead to flattening of the cornea. But it may lead to opacity. Am I clear, everybody? For a long time, obviously, number 1, it is not very easy to wear it. The patient has pain, the patient is uncomfortable, and then for a long time, because it is touching at the center, it is pressing it, opacity can do. Secondly, everybody, you can do keratoplasty. Keratoplasty, corneal transplantation, change the cornea, that's the best thing. Thirdly, to prevent the progression and to stop it from developing further, the treatment that is done these days is known as C3R. So what is the C3R, everybody? Corneal collagen cross-linking. If you are understanding the name, you are understanding the way this works. In the stroma, the collagen fibers, they are being interlinked to give it more strength. There is congenital weakness most commonly, yes or no? So if I give the collagen fibers interlinking more strength, everybody, then this will stop the progression and even resolve it for certain. Using riboflavin. Riboflavin is a photosensitizer vitamin. So riboflavin eye drops are put. After that, the eye is subject to ultraviolet A radiation, which leads to polymerization of the molecule and thus corneal collagen cross-linking. Okay, everybody, done? Please remember this name. Please remember riboflavin. Please remember ultraviolet A radiation. I hope I'm crystal clear about this. There should be no confusion in this. Done, everybody? That's all about our simple pathology, that is keratoconus, a type of corneal ectasia thinning leading to formation of a cone shape. Okay, now let's move on to the next miscellaneous condition. Very small condition called as band-shaped keratopathy. Very easily explained through the image seen on the screen. Now, if you see the cornea is transparent except the center where it looks as if somebody had put a band-aid and removed it. Once you remove a band-aid after 2 to 3 days, you will see in a shape of a band-aid deposit, yes, wherever you pasted the band-aid. So that's what it looks like. So there is white deposit. If there is white deposit, which is band-shaped, the first question which I will ask myself is, this is a deposit of what? White means calcium, deposit of calcium. Can I say in simple terms? Yes. Now if calcium is deposited, it is deposited in which layer? B for band shape, B for Bowman's layer. Okay. So how I remember it? Band shape, B for band, B for Bowman's. Keratopathy, calcium, okay. Keratopathy, calcium. So Bowman's layer, calcium deposited. Okay. What is the treatment? Treatment is chelation with EDTA. As simple as that. It's the simplest treatment ever, everybody. You take an earbud, yes. You dip it in the liquid solution of EDTA. You roll it over the cornea, yes. All the calcium deposit will chelate and the cornea will become clear. That's what band-shaped keratopathy as a pathology is to us. Very simple to treat, very simple to identify. No confusion, I hope done. Let's move on to the next condition. Miscellaneous condition, Arcus senilis. Again from the name, senile. Senile means old age. So this condition occurs in old age. Okay. What occurs in old age, everybody? Lipid deposition on corneal Descemet's membrane near periphery or in the periphery, whichever way you want to say. Senilis means old age, deposition of what, everybody? Lipid, which layer, everybody? Descemet's, and in the periphery. Now, that is where your diagnostic skills come into question. It is near the periphery. So a lot of students start saying it is at the limbus. Periphery of the cornea is near the limbus, yes, but that is the diagnostic sign of Arcus senilis. Let's see carefully. This is my Arcus. You can see the white deposit. Through red color, this is my limbus, everybody. So I'm marking limbus. This is my Arcus. Between the limbus and the Arcus, this green area, everybody, this is a zone of clear cornea. This zone is called as the lucid interval of Vogt. Lucid interval of Vogt is a clear zone of cornea between Arcus and limbus. Am I clear? That means to diagnose it as a case of Arcus senilis, you should see carefully that the lipid deposition, the white arc-like ring, is not touching the limbus. If it is touching the limbus, then it should be some other pathology. Then you have to think about other causes of corneal opacification. I hope I'm clear here. No confusion. There is no treatment for this. This is an age-related change. Now, next miscellaneous small condition known as interstitial keratitis. From the name itself, it is very clear. Keratitis means inflammation of the cornea, and interstitial means between. So, inflammation only of corneal stroma. Okay. No other part of the cornea will be affected ever. It does not progress to involve epithelium or endothelium. Only the stroma gets inflamed. Interstitial keratitis. It is a specific condition with specific causes. The most important common cause that we encounter is congenital syphilis. The second important cause is something called as Cogan syndrome. You may have heard about it or read it in ENT subject also. Interstitial keratitis along with deafness. Okay. These are the two main symptoms of Cogan syndrome. Then it can also be seen in cases of TB or in cases of herpes simplex virus. Okay, just remember two important things only of stroma and congenital syphilis mainly, and other some simple small stuff. Treatment will be steroids because it is inflammatory in origin. No brainer. Am I clear, everybody? Yes? Now, to finish the chapter of cornea, I will teach you keratoplasty. Okay, everybody? Another miscellaneous condition you can see. Keratoplasty, what do you mean by it? What is the literal meaning? Literal meaning is corneal transplantation. Corneal transplantation. You are changing the cornea. Now, keratoplasty can be divided into two broad types: full thickness or partial thickness. Full thickness is known as PKP, penetrating keratoplasty. Partial thickness is known as lamellar keratoplasty. Partial thickness I can further divide into two basic techniques. One is called as DALK, one is called as DSEK. Okay, what are the full forms? You will understand the names yourself, I hope. Deep anterior lamellar keratoplasty, Descemet's stripping endothelial keratoplasty. Okay, just write out the names, just understand these names, and I'll show you photographs of this. Okay, let's see the photographs. If I show you this photograph, what have I shown you? That I am changing all the layers of the cornea from the epithelium to the endothelium. So I'm calling it penetrating keratoplasty. Okay. When I show you the second photograph, DALK, deep anterior lamellar keratoplasty. So what am I transplanting, everybody? If you see carefully, I am transplanting the anterior layers. Okay. So what is being transplanted, everybody, in DALK? Epithelium up to the deep stroma. Okay. Whereas in DSEC, what are we transplanting, everybody? We are transplanting the bottom two layers. That is the Descemet's membrane and the endothelium. Are the photographs clear enough? In penetrating keratoplasty, all 5 layers. In DALK, the anterior 3 layers. In DSEC, the posterior 2 layers. So are we clear about this from the names? Descemet's and endothelium. Descemet's sitting endothelial. DALK, deep anterior lamellar. Anterior means epithelium, bovens, and the stroma. Am I clear to everybody? No confusion on this. Now, what are the indications for each of these procedures? Penetrating keratoplasty was earlier done in almost all the cases. But we say the most common indication is pseudophakic bullous keratopathy. Pseudophakic bullous keratopathy. Am I absolutely clear? Yes? Then DALK, deep anterior lamellar keratoplasty. This is usually preferred for acute hydrops in severe keratoconus. Okay, everybody? And DSEC can again be done in cases of bullous keratopathy. Am I clear, everybody? No specific indication for DSEC as such. I hope I am very clear about this. Now, once we know the types of keratoplasty, we need to know just a little simple information. How to do keratoplasty, everybody? Let's see this. So basically, let's say this is my cornea. Over this cornea, I have to first cut the host cornea to remove the damaged cornea. So we call this a trephine, everybody. You will be able to see the name written, trephine. This trephine diameter is 7.5 mm as written on the trephine itself. So the trephine is placed on the cornea, and up to a certain depth, it is punched. Either penetrating keratoplasty or deep anterior lamellar keratoplasty, whichever way. So this part of the cornea, let's say 7.5 mm, is cut and removed. Am I clear to everybody? So trephine will cut the cornea. Okay. Then what do? We implant graft cornea. We implant the graft cornea. Important point about graft cornea is its size should be 0.25 mm larger than host opening. Why is that so, everybody? Because after we put the graft donor cornea, we suture it, there will be some kind of contraction, everybody. So to allow for that contraction and the wound does not gape, we usually keep the graft corneal size 0.25 mm larger than the host opening. The opening is created by the use of a trephine, for which I have shown an image. Now, so after keratoplasty has been done, this is the kind of image you will be able to see. See, 360-degree sutures have been done. These are non-interrupted sutures. You could have put interrupted sutures, whichever way, everybody. There should be no confusion about this, right? So this is a post-keratoplasty image. Done, everybody? Now, after we have done keratoplasty, there are chances of graft rejection. Obviously. Now, the graft rejection can be due to problems in any layer, epithelial rejection, endothelial rejection, subepithelial rejection. The most common is endothelial rejection. Please remember this. Diagnosed by formation of something called as Khoda-Daust line. Again, nobody is going to ask you in detail, just remember simple stuff about this. Okay? Lastly, to end keratoplasty, what we should know, everybody, forensic topic, storage media. Number 1, short-term storage. Short-term storage is up to 48 hours. Okay? And it is done in what, everybody? 4 degrees Celsius moist chamber. Then intermediate term. This is up to 2 weeks. This is done in the McCarry-Kaufman media, MK media, popularly known as RISA. And thirdly, long-term storage up to 35 days. Though this is not to be done, still, if asked, the answer is cryopreservation. The cornea loses its viability to a large extent on long-term storage, even though we are doing it via cryopreservation at -70 degrees Celsius. Okay, everybody? Absolutely clear? That's all about keratoplasty in brief for you. That's all about my miscellaneous conditions, starting from corneal dystrophy, keratoconus, band shape and all that, and ending with keratoplasty. We are done with our cornea chapter. Again, I will say we have done 4 topics or 4 subtopics. Anatomy, special investigations, very important. I have explained to you. Corneal ulcer, very simple topic, and then some miscellaneous conditions. Cornea does not get asked too often in all the examinations. If asked, usually one question is asked from the chapter of cornea. I hope you have been able to answer. Right, guys? Done.
Finally 2 hours. ओके, थैंक यू सो मच जिन्होंने अभी तक देखा है. who have been seen. Thank you so much. I'm ending the live.